Good afternoon, ladies and gentlemen. Welcome to Grand Rounds. Welcome, John, in you come. I should pick out John because he's just agreed to do a Grand Round in May, so I have to be nice to him. My name's Tom Fardon, and I'm one of the I chair Grand Round today. Thanks very much for coming. Hopefully, we'll draw a few more people as time goes through this. Well, I'm very pleased to introduce to welcome an external speaker to Grand Rounds today. Iqbal contacted me a few months ago, as he's now the local rep for the Royal College.
College tutor.
Huh?
College tutor. A
college tutor for the Royal College in Glasgow, and he offered Professor Galloway's services to come and talk to us, which I think he was welcome. He was happy to do, to come and speak on the enigmatic title of The Clinical Jungle. I have no idea what that's going to be, but I'm sure it's going to be very interesting. And I'm going to just kick off in the normal manner and read out a few of our parish notices. Upside down. The university's Shihab Kigali, who will be well recognised to anybody who's an undergraduate here, or is involved in teaching, has been named to the board of European Team-Based Learning Community, a network of academics from educational institutions that will provide resources and development opportunities to team-based learning practitioners across the continent. He's the only academic from a Scottish university to be invited to the board. Team-based learning is a key part of the Dundee undergraduate curriculum, so much so that this very lecture theatre was designed specifically for team-based learning, which is why you're sat now in these little arcs around tables, because you are in your own little teams where you can learn. So well done to Shihab. That's the culmination of a good 6 years of work from him. And also congratulations to the School of Medicine's Pradeep Mohan, who discovered how to treat cardiovascular disease with the world's most common diabetes drug at the STEM for Britain event yesterday at the House of Commons. Pradeep was shortlisted from hundreds of applicants to appear at STEM for Britain, along Dundee mathematics PhD student Vasiliki Bitsuni. The annual event is organised by the Parliamentary and Scientific Committee, together with the Royal Academy of Engineering, Chemistry, Institute of Physics, Society of Biology, and early-stage researchers from the University of Dundee are frequently invited to showcase their work, so well done to him. A bit closer to home, in this very auditorium earlier this week, the Faculty of Medical Educators Awards, or the FAME Awards, were held with students coming together to celebrate the high standard of teaching in the School of Medicine. Prizes for the winners range from £50 to £500, and the money can be used to pay for textbooks and other educational resources, to complete qualifications, or for membership to professional societies. A full list of winners can be found in the news section of the School of Medicine website, and a photo gallery to go with it as well. And it's also on the school's Facebook page. Please feel free to find yourself and tag yourself if you're on there. So congratulations to all the FAME Award winners. This is completely organised by the students, voted for by the students and managed by the students. So well done if you won a prize. These are the staff development opportunities. Remember, the ones with the star have free lunch. And those are the opportunities going all the way through March. And I'll bring you the April ones from next week. Next week at Grand Rounds, we'll hear from Nikki Skembry and Magda, I still can't pronounce Magda's surname, Skevich, on interprofessional working relationships through clinical effectiveness and audit processes, and, as a bonus extra, the role of MDT in benign disease, so don't miss that. And then we pass on to Professor Galloway, who is the President of the Royal Society of Surgeons and Physicians in Glasgow, and he's going to present on The Clinical Jungle, so welcome. So that's your screen there. Try not to wander. Excellent.
So that's the screen, but it's blank.
Oh dear.
We did have it.
It did. It worked before. Yeah.
Here we go. Oh,
No.
it flashed up and then disappeared again.
Can I fiddle with your laptop? Why don't you sort of
Okay.
start the freewheel of it?
Well, good afternoon, everyone. It's a real joy to be here. And actually, one of the unexpected bonuses of just walking into this room is meeting some colleagues that I really didn't anticipate meeting. So first of all, I met a senior colleague, Ian Leddingham, who's come to sit at the back. Ian was one of the very senior members in the Department of Surgery when I was just a boy, many years ago. I won't tell you when that was. And a classmate, David Finlay, who's here. Didn't expect to see David, but there you go. And one of my JHOs from many years ago, Samira, who's sitting over there. So that's a real pleasure to meet these folks, quite unexpected. Now, hopefully we'll get the
Your laptop seems to run out of batteries.
Surely not. Don't think so.
No? Just a blank screen. Let's try.
Plenty battery, yeah. Let's just bear with us for a second. This was...
right, let's try plugging it back in again. There you go.
Good, okay. So, deliberately enigmatic title, but really what I want to speak to you about is the relevance of the college. And I had some discussion with, again, one of your senior clinicians just outside before we came in, just about what the colleges actually do these days. But hopefully in the course of this next half hour or so, I'll be able to unravel some of that. And I want to add a little bit of personal clinical input, partly for your entertainment and partly by way of a little bit of a spot diagnosis test. But we'll come to that in due course. So the clinical jungle. But we want to talk about problems, politics, participation, and, if there's time, professionalism. A word or two about the Royal College of Physicians and Surgeons, which is a global college, footprints in Glasgow, formed in 1599 by a royal charter granted by King James VI of Scotland to become, of course, King James I of England. I'm always quite keen to point that out to my colleagues south of the border. And it was really founded by three people, the lead of whom was this character, Peter Lowe, who originated in the west of Scotland, we believe, was born about 1550 or so. There were no medical schools, of course, in those days in these islands, and so he went to continental Europe and trained partly in Padua and in Paris, and came back to Glasgow in the 1590s, having served the King of France for many years, was involved with various famous surgeons in war surgery during the unrest that was going on at that time. And when he came back to Glasgow, and came back to Scotland, realised that there was so much quackery going on and so many horrendous examples of poor clinical practice being foisted on the nation and on the people of the west of Scotland, that he approached the king for a charter to examine surgeons. If you were a physician in those days, it was pretty straightforward. All you had to do by then was to present evidence of your diploma from a university that you had qualified in medicine, and you were in. But if you were a surgeon, you had to be examined, and if you stepped out with the bounds of your credential, I can almost sense these things coming again, you were fined. And the history of the college is just peppered with these incidents where people were pulled in and asked to justify their input. Peter Lowe was one of the first surgeons who contributed in English a book on general surgery. He also wrote a piece on the Spanish sickness, which you'll realise, of course, was syphilis. And over the years, we've had a number of quite well-known famous fellows, including these two characters, David Livingstone, who probably wasn't the easiest character in the world to get on with, but of course he spent much of his career as an explorer in Central Africa, and we'll come back to Africa shortly. But also Joseph Lister, who, when he was in Glasgow, became Professor Joseph Lister, and then soon after that became Professor Sir Joseph Lister, and actually in what was then the College Hall, which is now one of our period rooms on our St Vincent Street site in Glasgow, he delivered what was to be one of the practice-changing demonstrations of what was then known as the germ theory of putrefaction. And he gave a lengthy exposition of that in what's now our Alexandra Room, but was then the College Hall. So Lister is a major figure in Glasgow and indeed in Edinburgh surgery, and ultimately he went back to London where he first qualified, of course. So what do we do now? What about the relevance of the college these days? Well, we're involved in a whole range of things. Our core activity would really be education and assessment, I suppose. I'll say a little bit more about that in a moment. Just as you have in Dundee, a very superb, in fact, clinical skills setting with the Cuschieri Centre, we have a similar, somewhat different, but similar setup with the University of Glasgow, which is involved in the high-end simulation training, and some pictures of that there. And so that's really part of our core activity. We're very keen for people to really engage with us and get involved in that. It's an essential part of what the colleges do. But let me get to my 4 points, and we'll deal first of all with some of the issues. I noticed that as far as problems are concerned, I may be wrong, but Tayside seems to be at least off the agenda a little bit at the moment. But when you look, and we did look a few years ago as colleges at the serious failings, and just a moment's thought, you can begin to rhyme these off. Mid-staffs, the Bristol Heart event, of course, back in the 80s, but from mid-staffs, there's been in Scotland, Aberdeen, the Vale of Leven, Lanarkshire, Crosshouse in the news this week. All sorts of difficulties with leadership and management and clinical failure and what have been called serious failings in care. And so the colleges actually, I think, importantly addressed this and tried to pull together some of the lessons that could be learned from these serious failings. And you can see on the left there, these are the kind of common themes. Not surprising, I'm sure, to any of you here, but these were the features that figured in just about every one of these. And yet we seem to keep having to reinvent that particular wheel. And so what we're doing right now as colleges is going around the country with a series of events which are under the title Prevention Through Learning, trying to pick up and engage on some of these particular issues. Very specifically, you may recognise this monstrosity, which is the new Scotland super hospital, so-called. Well, we're having to do a bit of a review there. The colleges are involved in that to some extent, but we're reviewing a whole series of services because of perceived failure to meet particular targets. So that's just one of the areas that we tackle in terms of the sort of problems that we face. Very briefly, just about the political scene. Where do you start? Well, of course, last year it didn't affect us here in Scotland so much, but it's a huge problem in the NHS with the strikes that were going on and our attempt to engage with the political leadership, such as our dearly beloved Secretary of State for Health. And of course, this year it's hardly been off the headlines, this sort of so-called crisis. I've been blogging a little bit about this, and of course, even this week, thinking about the sort of turmoil, and coming to Dundee, I hesitate to make any particular comments about this topic, but it looks like we're back into some further discussion and argument and likely division on the whole question of Scottish independence. Well, we'll see. Enough about that. Let me just say a little bit about participation. And on the participation front, I wanted to say a bit about what the colleges do in a more general sense, and then I'm going to share with you some personal experiences which I hope you might find interesting or entertaining. So there's what we do, and I think this would be true of all the colleges. I'm pleased to say that the relationships between the Scottish colleges is really very warm and collaborative. Of course, there's an element of competition. We are vying for your interest and your engagement and your membership and fellowship and so on, of course. But nevertheless, we do a lot in common, and that has been one of the most satisfying aspects of my involvement with the colleges. It's all about setting standards, so whether through education or through examination and assessment, but also through CPD, membership benefits, all the many things that the colleges are trying to be better and better at. And in Glasgow, during my time, we've tried to introduce a whole series of new initiatives. So we are embarking on a modular MSc, initially in advanced surgery, with the University of Glasgow. We're running now an Academy of Clinical Educators to try and recognise the fact that the GMC now require you, if you're involved in teaching and training, to have some credible evidence that you can present to your local education organiser that you're a card-carrying trainer. So we'll help to support that with various events on education and leadership and management and so on, as well as involving people to actually be faculty on our teaching and training programmes. We run, perhaps uniquely, as an interdisciplinary college, and this is one of our selling features in Glasgow, being a college of physicians and surgeons, and indeed dentists and travel medicine specialists and podiatric medicine specialists. But we have a whole series of events that cross these particular interdisciplinary lines. And then global health I'm going to come back to. And of course, I was chatting to one of your colleagues earlier on here about the sort of heritage element of the colleges. The colleges have these incredible treasures, ancient books and works of art and so on, and it really all comes from the time when they were making so much money. This is not for minuting. The treasure didn't know what to do with the profits, frankly. And so that was the genesis of much of the kind of art collections, which I'm slightly embarrassed about now. Anyway, let's move into the global scene. I wanted to say a little bit about global surgery and about the major killers, because this is an area of increasing participation, not just of the colleges, but I would challenge you to think about your role in Western medicine in this particular context. You know, we think of the major killers being these three conditions: malaria, HIV, and tuberculosis. And looking globally, these are the number of deaths annually that are reckoned to result from these particular killing conditions. And I think we would all recognise that. What I think didn't become clear, and now Western medicine and surgery is beginning to wake up to, is this fact, and it came out actually almost 2 years ago, almost exactly 2 years ago, with the Lancet Commission on Global Surgery, when they indicated that, in fact, if you are able to eliminate or at least have a significant dent on the number of deaths arising from conditions that can be readily tackled by simple surgical means, the number of deaths involved there come to many, many more than all of these killing diseases put together. And so that was a staggering fact. And when you put it into the background of what the global surgical scene is like, the reality is that if you look at the provision of basic surgical and anaesthetic care, we're talking here about access to services that can surgically deliver a baby, make an emergency laparotomy, or do a fracture fixation, if you like, then about 5 billion people of the almost 7 billion people in the planet population do not have access to that degree of service. And that is staggering. And of course that tends to apply particularly in the countries that you might predict. So particularly in sub-Saharan Africa, but also in India, parts of the Far East, and so on. And so this is a huge challenge. And I think there's a moral imperative upon us, because we have the resources and we have the ability and we have the expertise to at least get involved in this, and maybe we should. And looking at some of this is galling, I think, to me, because while a third of the world's population live in these under-resourced countries, only about 6% of the available medical staff would apply in these settings. And of course, if you were to look at the number of procedures performed annually, just thinking in general surgical terms, something like, and the estimate is 313 million, to get up to some kind of reasonable standard, we need another 150 almost million procedures in order to begin to address that need. So let me tell you about a little bit of personal involvement. I retired from clinical practice in Glasgow, where I was pretty much a colorectal surgeon and latterly became a bariatric and metabolic surgeon, which is a kind of uneasy combination of specialties. But nevertheless, I had a fairly broad-based general training, and so with some fear and trepidation offered my service to a mission hospital in northwestern Zambia, right there where that marker is, right beside the Zambezi River, which runs kind of vertically down through Zambia at that point. Angola is off to the left, Congo, of course, up to the north, which is a pretty unsettled sort of place to be. But Zambia is a fairly stable country. And of course, we think of Zambia, we think of these kind of tourist destinations, you know, the wildlife and the Livingston, Victoria Falls and all the rest of it. Getting from Lusaka to the station that I was based in for a couple of months last year, and then again for a month just a few months ago, involved a flight in the Cessna 206 like this. And some of you will have done this kind of thing, and I'm sure you found it to be both challenging and in many respects life-enhancing. But this is Chitokoloke International Airport. As far as the local services are concerned, there's what the local ambulance looked like. A moment's thought, you think, it looks quite good, until you look at the wheels and you realise, well, there are no wheels worth speaking about. Anyway, I arrived at this hospital, which is quite a small hospital, 4 wards, a male ward, a female ward. Number of beds is irrelevant, because if you need more beds, you just throw mattresses down on the floor, a bit like 9 Wells, I guess, at times. And when I went in, I went first of all to a clinic. And there was a surgeon there, a British surgeon who trained in Belfast, actually. He's about my vintage. He's spent his entire career in Central Africa. And he was to be my mentor and tutor in terms of all matters tropical. And he was keen that I use some of my general surgical experience in applying that to his particular population of patients. But he said, hey, David, go in behind the screen there and tell me what you think of that patient. And this is where your spot diagnosis skills come to the fore. There was the very first patient I saw in Zambia. Any takers on a diagnosis? Yeah, that's usually the reaction I get, because not too many of us have seen something like that before. I used to read an old textbook called Hamilton Bailey's Signs, Surgical Signs in Clinical Practice, and they've got some advanced pathology in there, but let me tell you, it's nothing compared to the advanced pathology that you see in Africa. And that was patient number 1. That turned out to be a dermoid. And in my significant wise surgical judgment, I decided that was not for operating on. There's the second patient I saw. I'd never done any eye surgery worth speaking about, but the following day enucleated that eye. This is a young girl who's got the result really of a corneal injury and essentially loss of her eye. Meanwhile, outside there's the clinic line. These are all the patients waiting to be seen. They heard another doctor was in town, and so the line got longer. And even at the end of the day, it's still that long. It just seems incredible. But the number of different and diverse things that you just have to deal with there, you just have to kind of do it, include some cases like this. Have a look at this. Here's a 12-year-old girl with what looks like a maxillary swelling. Now, I hesitate to show this to any oral and maxillofacial surgeons, but there she is from the side. And you can probably see from her standard radiography that, in fact, what she's got are some evidence of teeth, ectopic teeth up in her maxilla there. Certainly quite a few ectopic teeth there, and we thought this was a dentigerous cyst, and never done anything quite like this before, but broached into the mouth and made an approach on her maxilla and dug this thing out, and in fact there it is. It looks a bit nasty, to be honest, but there is no pathology there, so we never knew whether it was an ameloblastoma or something quite simple and straightforward. In terms of advanced pathology, what do you do with someone who presents like that? It's not the kind of thing we have any experience of in Western medicine or surgery. This is a neck lump to end neck lumps and looks like it's completely non-treatable. Is there radiotherapy in Zambia? No. Is there cardiac surgery in Zambia to treat all rheumatic heart disease? No. So it's a desperate situation. Things that you can easily fix would be things like this. This is club foot, feeding programs for the malnourished kids, but dealing with these big jaw tumours, it's a major problem. There's another example of a young girl that ended up having half of her mandible removed. I'll show you this because I went there initially in September, October, and I was somewhat frustrated that the mangoes weren't quite ripe, but there were mango trees everywhere. And one of the characteristic things that I learned about when I went to Central Africa was the new diagnosis of a mango fracture. That's a mango fracture. The kids shin up the trees to the top to get the best of the fruit, fall out and break their long bones. And of course, is there orthopaedics? No, there's no orthopaedics either, just a bit of basic surgery and maybe some traction. And so around the wards you've got people in Thomas splints and you've got people in various forms of traction. And of course, one of the other competing elements of the practice is this, and this is an example of it. This is a picture of someone's back who of course has been to the local village shamans or equivalent of snake oil salesman and been to the witch doctor, and you go with a sore leg and they'll scarify your leg, and you go with a pain in your back and they'll deal with that. They don't quite know what to do with this. Spot diagnosis, anyone? People usually get this one actually when I show this. That's zoster. Trigeminal zoster. Anyway, what I wanted to speak about were some of the specific dangers which are quite different from the practice that we have on the banks of the Clyde or the banks of the Tay. And of course, malaria would be one of the features, and it's so common. It's like the cold there, people get it all the time. Do they bother with mosquito nets? Well, the local people generally don't. They use them for goalposts, the kids. They don't have anti-malarial medication in any meaningful way. They don't have medication to treat this organism, which is Schistosoma mansoni, which is absolutely hoaching in the river Zambezi. Of course, the result of that is that people have quite marked portal hypertension, and so just in a clinic, one clinic afternoon, you get pictures like this with the caput medusa, from portal hypertension. Here's my hand on an abdominal wall. That's my hand on the left. That's the spleen on the right. So just about everyone in that community has an enormous spleen. And we had a medical student there, and one of the little projects I suggested to them was that they might go around the ward and just, for the patients that did happen to have a haemoglobin measurement, just to get this sort of median value, 7 or 70 in modern terminology, was the mean value. How about trauma? Trauma is real. This is fairly superficial trauma, but does anyone recognise the geography of that? I'd never encountered this in my life before, and certainly we don't see too many of these in the Clyde. We see some of them in the hospitals, a few dinosaurs, of course, but that was a crocodile injury. And I think I amassed a personal series of about 8 crocodile attack injuries in 2 months, which was quite incredible. Just the week before I arrived, a 14-year-old boy had been taken by a croc in the river. And the river was only about 300 metres from the hospital. All the local people go to the river every day. That's where they get the water. It's where they wash their clothes. It's where they get their laundry done, where they clean their cooking pots and so on. And so every day you see them trekking up from the river, and just about, not daily, but on a regular basis, people from the local villages are attacked by crocodiles, who of course are pretty opportunistic and lightning fast when they go in for the kill. Here's another patient. You might want to avert your eyes, but that's a crocodile attack injury that we had to deal with. Patient survived, came to hospital. You can see an hour or two after the injury, and you can see the teeth mark around the torso there. Patient did very well. Here's another one. So it's certainly a feature of that particular community. Other wildlife too. On one particular ward round, I can remember seeing 4 patients in the ward with tissue loss from 4 different species bites. One was a human bite, lost their finger. One was a crocodile bite. One was a snake bite. And one was a hippopotamus bite. And again, you don't see too many of these in Western practice either. That's the wee lad of about 12 or 13 who lost his forearm having had a puff adder bite and a guillotine amputation. Ended up with some skin grafting. And here was a wee girl who came in just a day or two before I left on my first visit to Chitokoloke, and that was the only evidence of injury, but she was virtually dead. They were jumping in her chest when I arrived to see her about midday. She'd had a snake bite attack about 8 o'clock that morning, and instead of bringing her to the hospital, it was only a kilometre or 2 away, they took her to the witch doctor and they messed about, gave her some village medicine, and with a neurotoxic venomous injury, she began to suffocate essentially and came in not breathing. Resuscitation failed. She was 8 years old. And it turned out she was the sister of the boy who had been taken by the croc in the river about a month or so earlier. So life is tough for these people there, there's no doubt about it. But even common things, even simple, pyogenic infections, have a look at this. That's the lateral view of a knee. You can probably just make out the articular surface of the femur there, which is badly damaged and eroded, a lot of necrotic tissue around. A simple injury, which had become chronically infected. Burns, of course, will stricture down, and you get contractures like that. And how about this guy? This is one that I will never forget as long as I live. This is a guy called Moses, who came, having walked for about 4 days from Angola across the border into Zambia, came to a mission station about 40 or 45 kilometres north of where I was, with no doctors, 2 Japanese nurses, who instantly recognised this guy was as septic as could be. He had lost all the skin over his anterior neck. I'll show you that in the next slide, so you can see his strap muscles quite clearly. It's not a great picture, I was just taken with my phone. Elsewhere in his chest, he'd lost the skin over his anterior right chest wall. The rest of his chest wall was really floating in a sea of pus. He was just as sick as could be, this guy. And his chest x-ray looks like that. So he's got a big pyothorax, pneumothorax as well. And I attempted to get some video, because when he breathed, this fellow, I hope this plays, yeah. So he's got an open fistula into his thoracic cavity with all this pus bubbling out. And of course, in the NHS these days, you can pay a lot of money. Plastics guys sometimes use little sterile packets of maggots, to help to tidy up wounds. These are the free-range maggots available in Africa, which were pretty effective at cleaning away all the necrotic tissue. So pretty desperate. This poor guy had intensive treatment with parenteral antibiotics for a month or so, and ultimately, unfortunately, succumbed to his diagnosis, which was a dental abscess. Staggering. The kind of thing that you would never anticipate, and yet is not that uncommon there, where there's no dental services worth speaking about either. African sunburn in an African albino with a pretty nasty looking tumour at the outer canthus of his left eye. There's the close-up with its resident fly, probably a BCC or maybe an SCC, but likely due to UV damage. He's got no protection in terms of natural pigment. How about this? Any takers on this? Sometimes people get this one, even although we don't see it too commonly here. Any infectious diseases specialists in the audience? HIV. This is Kaposi's sarcoma. And the tragic story about that girl is, in fact, she was a very intelligent English-speaking teacher who was on antiretroviral therapy. Her Kaposi got better, and when she got better, she stopped taking her medication. The whole thing flared up. She died of AIDS. And so this is the kind of difficulty that you're dealing with. And when I was there, actually, I was not just the head and neck surgeon. I was the urologist. I was even the obstetrician, orthopedic surgeon, plastic surgeon, you name it. You just had to do everything. This young girl had an obstetric fistula that we ended up operating on. This is a specimen from a 6-month-old child with a duplex kidney which was infected. I'd never done an operation on a 6-month child in my life, but, well, there's no one else to do it. And just as I was leaving, and this is how this service is sustained, this other fellow appeared. He was from Spokane in Washington, again a general surgeon, just newly retired, a bit like me in many ways, and there we are working together on a big abdominal mass. And sometimes one of the other features of working in Africa, and this next slide is an emergency case, when all of a sudden, just as we were getting towards the end, the power goes down. And so it's amazing what you can do with a light from an iPhone. It was also quite fun to set up their minimal access surgery, but being in Africa, there are times when nothing really seems to work properly. So we had this setup of an insufflator and all the stack you needed for keyhole surgery, except there was no power cord for the monitor. And so we had identified a patient who was ideal for this. There was a fellow who was brought in from the local prison with severe hyperhidrosis. And there was a great debate as to whether there was anything we could do for this guy. And I kind of suggested that it might be worth trying to deal with his thoracic sympathetic chain and do a sympathectomy, and that would solve his hyperhidrosis. And so because the monitor wasn't working, I had to do it Lord Nelson style with the laparoscope or the thoracoscope up at my eye, which you can just about see there. And we went in and divided his sympathetic chain, and he ended up a very happy man with 2 dry hands. On my next visit, we managed to get a power cord for the monitor, and so we made history in that hospital by doing the first laparoscopic case with some of the local team that you can see there. Lots of issues. You know, I could entertain you. I've got millions of these photos which would keep you going for a while, but enough's enough, I think. But whether you relate to the medical services or the facilities in the hospital, the poor nutrition or the advanced disease or just the state of the environment, there are all sorts of problems that actually we can help with up to a degree. One of the big issues were there were no signs of significant specialist support. And interestingly for a surgeon, one of the quite satisfying things was that neither was there any anaesthesia. And so you become quite adept at spinal anaesthesia, and you learn a fantastic respect for a wonderful drug called ketamine, under the influence of which you can do just about anything to anyone. But it would be wonderful to have some good quality anaesthesia. When we did need anaesthesia, such as for that paediatric case I showed you, or for the thoracoscopic case, the person who gives the general anaesthetic is an Irish midwife. And she is fantastic. It's indistinguishable, at least from the surgeon's point of view, and you might say that's not particularly discriminating, but it's indistinguishable from the service you get from a consultant anaesthetist in the UK. What do you do with other issues? Well, need for major transfusion. I gave you the hint that portal hypertension is a big deal. What goes with that? Esophageal varices. People come with huge bleeds. They don't really have any significant blood products. I took delivery from the airstrip one day of the entire month's supply of packed cells, 4 units for the hospital. And so local mission staff, teachers and others that we know to be O negative are hauled in, and fresh blood is donated and given as required. And so a fair number of people lose their lives because there's no blood transfusion. The need to do fairly significant things to people. One of the features of social life there in in that part of the world is if you want to take it out on someone that has offended you, the way you do it is you drink some battery acid, and of course you end up with a significant caustic injury in your esophagus. And that's kind of what the esophagus begins to look like as it gradually strictures down. Very difficult to treat that, even in the UK. And I was up for doing a colonic interposition on this particular patient, but just the lack of support. There's no ITU, there's no lab support worth speaking of. So what do? There's really no support. So it's a kind of life or death. This patient is almost certainly going to die in a few weeks of acute malnutrition. They don't have significant quantities of enteral feeds, certainly no parenteral feeds. Huge problem. Well, what about obstetric or post-obstetric care? I'll show you that just as a kind of intro to this next issue. I can remember a young woman who had a big bleed during childbirth, ended up with Sheehan syndrome, was agalactorrheic, So how do you deal with that? Well, of course, in the UK you go to Boots and you buy some bottles and a steriliser and you get some formula. It doesn't exist there. There is no surrogate that can do the breastfeeding. There is no formula. There's no bottles or sterilisers. What do? You buy them a goat and you give them a cup and you feed the kid from a cup goat's milk. And actually, they seem to do fine. Very interesting. It wasn't all taxing. There was just one little tourist opportunity. I'm going to show you a picture from the National Geographic of the Chinyingi Bridge over the Zambezi. I don't have any meaningful pictures myself because when I went there it was pitch black. We didn't time our trip properly and it was after sunset. But that's what it looks like. It's a homemade suspension bridge, just a pedestrian bridge, single track. You have to kind of turn sideways to walk past people that are coming in the other direction. That's what it looks like. And of course the thing bounces. You can probably just about see from the handrail, it looks like it's made of barbed wire, and it certainly felt like it was made of barbed wire. Crossing that at night in the pitch dark was an experience I don't care to repeat, frankly. But that was one of the famous tourist attractions in the area. It was built by some Roman Catholic priests, literally from bits and pieces that they pulled together from mining companies and other industrial organisations, and they got the whole thing together. They slung these wires across the river and put that suspension bridge up about 25 years ago. Quite amazing. One of the things in the Glasgow College that we're working on is this whole question of global citizenship, and I think our Chief Medical Officer, Catherine Calderwood, is intrigued by this concept that we want to try and make it more feasible for people in the NHS to have the opportunity to make sure they use their sabbatical time or take the opportunity to be released from their clinical commitments to go as a volunteer perhaps, or even as part of a paid project or a supported project to work in the global environment, if you want to put it that way. And there's huge opportunities for us to support, maybe even without necessarily going, but just somehow remotely supporting education and training. And so that's something which I think is very enticing. And we're about to produce a report which will be trumpeted in May of this year, which is on global citizenship, and I hope you'll get a chance to see that and maybe even follow up on some of these ideas. A huge challenge, but it's enormously enhancing. Who benefits? You benefit. Your patients benefit. The system here benefits. I mean, that's been well demonstrated. HEE, Health Education England, are pretty well advanced along this track. We're a little bit on their coattails currently in Scotland, but I hope that that's something that we can address. Tom, I think I'm going to stop there and not deal with the professionalism issue. It's opening up a whole different angle. I'm conscious of the time, but I think we'll pause there, and I'll be happy, if you wish, to take questions. So thank you very much for your time and attention.
Right. That's fascinating stuff. Anybody got any questions whilst I desperately search for the microphone? I think they've locked them away from me. Oh, here we are. Anyone any questions or comments? Anything you'd like to say? That's right. We've had a couple of people at Grand Rounds over the last few years who've been on similar trips. We had a chap who's been to Uganda, and one of our own anaesthetists has been out to similar areas, so we do send some anaesthetists to go and help out plus the blood-brain barrier. And the last time I went to Africa was a long time ago, well over, knocking on 20 years since I was in Uganda, and saw very similar things. It's depressing to me to see that even just last year, not much has really moved on. Can you try to think of what's the one thing that would make the biggest difference?
Well, I suppose the one thing that would make the biggest difference would be if we could somehow support and resource their clinical officers. What they don't really need, I mean, they do need surgeons to go, they do need specialists to go, but they really need people who can deliver simple, basic care on the ground. And just as we are developing a whole profession now in the UK of physicians' assistants or associates, and they work in surgical care and critical care, in anaesthetic practice or work in general practice and so on, so there we need really clinical officers, and so we need to be able to train that group of professionals to the level that they can at least apply basic care. Now, some of them will be doing basic, simple surgical procedures. You can train clinical officers to very safely repair a hernia. It's a huge problem in Africa, which is largely untreated. And so I think that would be the single biggest thing that we could readily do to begin to address this huge gap in care, the huge gulf that exists between the first world and the third world, really.
And what if people are out there in the audience wanting to do this sort of thing? It's notoriously difficult to get a sabbatical. I've got colleagues who've had them turned down for very worthy things they wanted to do. So what's your take on that?
Well, my personal experience was I did take a sabbatical before I gave up clinical practice, and it was a pretty straightforward process, I have to say, in Glasgow. But it is built into the consultant contract. It is your right to have a sabbatical. I think it's up to the health board whether they decide to support you with a salary, but I think they will often support at least 6 weeks of the standard sabbatical with a salary, and that's been commonly the case. And from the college point of view, I think we would be very keen to help, as with the BMA, and get into the discussion if people were having difficulty and had a particular project. And in the light of this global citizenship that's going to be strongly supported by the Scottish Parliament, I anticipate we're about to set up, I'm not quite sure where it's going to be, but there will be a coordinating centre for global health in Scotland, and that's exactly the kind of advocacy group that would be able to apply a bit of pressure and help people find attachments and so on, and perhaps facilitate the administrative resources that are needed.
Oh, a question from the audience.
Thanks. So a lot of your stories were very moving, and you present it as you said it's a life-enhancing and it's a positive experience, but personally I've also found it overwhelming to see that level of suffering, and for every operation that you do, there's many operations, many patients that we haven't been able to help. So do you have any advice kind of philosophically about how to deal with that kind of pressure as a physician or a surgeon when you're not able to help everybody?
Yeah, no, you're right, it's difficult. You just have to realise that it's a problem you can't deal with on your own. Even a team of people going out, teams of hernia surgeons go to Papua New Guinea or go to Siberia or whatever, and they'll work away and they'll treat a load of patients, and these patients, fantastic. But nevertheless, there's still such a huge unmet need. I think, to be honest, what we really need to be tackling is not so much this kind of episodic involvement, much as that is of some limited benefit. I think what we really need is a more coordinated approach to strengthening the system. And that's why I think the clinical officer programme, for example, is such an important one. So I think we need to think innovatively, not just think about how we would tackle a particular problem here and try and translate it there. We need to think about their context and how to build that service and that system. So, and I think there are many groups and many people beginning to do that. So one example, for example, would be the Scotland-Malawi partnership, which is quite well known, high-profile, charity-based, supported by the Scottish Government, supported by many of the universities. And so they do some fantastic work in terms of training and teaching and system strengthening, if you like. I think that's the real need that's required out there.
Just wondering what you think we can learn about healthcare provision in the UK from your experiences or other people's experiences in areas like this.
Yeah, I think it's a little bit more difficult to define that. I think what you do come back with are unexpected skills, so you have to be very adaptable, and you'll be facing challenges and difficulties and workarounds that don't necessarily apply here, but it gives you that sort of sense of management skill, leadership skill, which is quite difficult to define. So when I say it's enhancing, I think it's maybe a little bit nebulous, that, but I think you do come back with resources built in which result from your time in a setting like that, which I think will spill over into your approach to clinical problems and administrative problems and workarounds that you need day and daily in the NHS,
When I was watching your presentation, it struck me that because of your generalist training, you were able to turn your hand to a number of different situations that you were faced with. And I just wondered whether or not you think the next generation of doctors will be able to do this type of thing, and is that a problem for what you want to see happen in the developing world? Whether or not our current generation of doctors will be able to turn their hands to a number of generalist skills that you
Yeah, I've thought hard about that particular question. It's a very good, important question. I think undoubtedly I came from a generation where, we were rotated. I mean, I was personally rotated into neurosurgery and into plastic surgery, urology and so on, vascular surgery, etc. That maybe happens to a lesser degree now than before. Nevertheless, I do think that with some basic surgical skills and an internet connection, you can achieve a huge amount, actually. And it does require a degree of professional courage. You're certainly out with your specialty comfort zone for sure. So I've spoken, for example, to a very prominent, very skilled, very highly regarded hepatobiliary surgeon in a city not far from here, and said, why don't you get out there and give them a couple of months of your time? And he was horrified at the thought that he might have to treat somebody with a scrotal problem or somebody with an orthopaedic problem or do a skin graft because, he's got a vague recollection of maybe seeing that kind of stuff but didn't really have any hands-on experience. I think you can get that experience. And in that setting, maybe the only way to get it is to go and do it. But with the basic surgical training or medical training that we have here, I think we can apply and do a lot, contribute a lot. Now, on the medical side, I was at sea half the time. I'm treating patients with hypertension. I know virtually nothing about what the modern treatment of hypertension is, or how you deal with somebody with mitral stenosis when there's no cardiac surgery, and how you muck about with their diuretics and their various drugs and so on. So the drugs are there, but to have somebody with a bit of specialist knowledge going into that setting with a general medical background would be a tremendous benefit. Just to look at systems, set up systems and policies and so on that would have an ongoing effect. So I think physicians have a huge amount to contribute, even though they're not perhaps so much hands-on. I think it's been a great benefit to have a general background, but I'm not sure that it's completely essential.
Any more questions or comments? Okay. I think you're very brave. I think to go from a background of attacking abdomens to facing that dental abscess, and you're very glib. I just took out that thing in this woman's face. I think it's a testament to you that you felt confident enough to go and do that and had such success in doing it. I think we are trained to be very specialised these days, and I think you make it sound very straightforward and very simple, but I'm sure it's absolutely not. And I think it's to your credit that you did that. So I'd like to thank you for coming. Thank you for your interesting talk. Thank you all for coming. Next week, the radiologists come out of their darkened rooms and they're going to talk to us about how it's not all about looking at screens. Some of it is about multidisciplinary working in benign disease. And Nikki and Magda will be here next week. I hope you'll be here too. Thanks so much for coming.
Good. Thanks very much.